As a surgeon, I've been invited to talk about surgical options for kidney cancer, which is a topic near and dear to my heart. So, a few disclosures. Number one is there's rarely one right answer for treatment of kidney cancer, and I think this is a theme that we've seen throughout the course of the day, where we've kind of gotten away from one option for each patient and to, one. It's not a one size fits all approach anymore. We really need to tailor to individual circumstances. And additionally, each surgeon's approach and outcomes really vary. And I'd like to thank my colleague, Dr. Westerman, for some slides and concepts for today's talk. You guys have heard already that kidney cancer is a common cancer in the United States, and that treatment selection depends on tumor characteristics, patient factors, and disease stage. Surgery does remain the primary curative treatment for localized disease, and it's really important to have a multidisciplinary approach because we know that can optimize outcomes for patients. So today I'll speak to you about who should have surgery, different techniques, methods, and approaches, what to expect after surgery, and what type of surgery might be right for you. So number one, we heard a little bit from Dr. Rose about how the standard approach really varies for even systemic treatment based off of the provider. And additionally, each surgeon is different. Each surgeon is comfortable with different techniques and approaches. And I think it's really and is trained in different ways. And I think it's really important for surgeons to approach things how they're comfortable and what is best for each individual patient. Additionally, you heard from Dr. George that every tumor is different and that it's important to get imaging and to look at the tumor location, whether it's, kind of on the outside of the tumor, whether it's a more centrally located tumor, and all of those things affect how we approach surgery and how we approach treatment overall. So my goal as a surgeon is to find the right surgery for the right patient and to balance the risks of intervention and the risks of disease. And when we're doing that, we think about both patient factors and tumor factors. And so patient factors involve age, performance status, whether they can tolerate surgery, and honestly, whether not only can we get them through surgery, but can we get them back to a really excellent quality of life afterwards? And discussing what each patient's individual goals are, and can we achieve those goals? That's really important for me when I'm having discussions with patients before surgery. Their baseline renal function, other medical conditions that they may have, and how those impact surgery. And then also whether they have a solitary kidney and the impact of our surgery on their overall renal function and whether patients might need dialysis afterwards and having those discussions, getting them in to see a nephrologist, things like that. We also think about tumor factors, so size and location, as I mentioned, the stage of the tumor, as Dr. George kind of outlined, and then we use something called nephrometry scoring, either through the renal or the Padua scales, and that really indicates tumor complexity and whether and can be used as a scale of whether we can do something called a partial nephrectomy, where we're just removing the mass and a little bit of normal kidney around it, or whether we have to remove the whole kidney, and I'll get into that a little bit. And then also anatomic complexity. So who, what, where, when, why, how do we approach all of this? So when do we consider surgery? First of all, tumors that are too big for active surveillance. So a lot of times when patients have tumors that are less than 3 centimeters, we can just watch them safely. We know that the risk of metastasis or spread to other locations in the body is low when tumors are less than 3 centimeters. It's not zero, but it's low. And so a lot of times we'll have discussions with the patient and shared decision making to decide whether do we watch it now or do we intervene? We need to make sure patients are healthy enough for surgery, no sign of cancer elsewhere. And sometimes even if there is sign of cancer elsewhere, as you've heard, we will still do surgery if patients are going to benefit from it long term, or if they're having symptoms such as bleeding or pain from their cancer. You've heard as well about the concept of a cytoreductive nephrectomy. This is when we remove the primary tumor or the tumor in the kidney in the setting of metastatic disease. This is really an individualized choice. We collaborate a lot with our medical oncologists, radiation oncologists, radiologists to decide whether, based off each patient's tumor biology and other factors, whether this is the right choice for them. In general, patient selection criteria is that they have good performance status, that we can resect the primary tumor, that they have low volume or limited metastatic disease. And you've heard about different histologies as well, and for this, clear cell is preferred. However, like I said, it really is a shared decision-making and collaborative choice throughout the different specialties. We have multiple types of kidney surgery. So um, number one, we talk about how much kidney we're going to remove, whether we remove just the mass or the whole kidney. We can do surgery open, robotic, or laparoscopically. And then we can approach it multiple different ways. So we can go transperitoneal, which is going through the front of the abdominal wall where we're kind of right next to the bowel, or we can go through kind of the flank or the back, which is more retroperitoneal. For a partial nephrectomy, you can see here on the right side of the screen, that's when we remove just the tumor, a little bit of normal tissue around it, which is that dark kidney parenchyma, and then we sew the defect in the kidney up to prevent bleeding. And this allows us to preserve kidney function. During the surgery, we do temporarily clamp the renal artery. And so we do cut off the blood supply to the kidney to prevent bleeding during the surgery. And that can have a transient impact on on kidney function. But depending on how much tumor or sorry, how much normal kidney we have to remove during this process, this allows us to really preserve kidney function and can be an option for small tumors. And we really try to do it when patients have a solitary tumor, a solitary kidney as well. Potential complications is bleeding. You can have a urine leak. So if the tumor involves the collecting system of the kidney and we have to cut into the collecting system, we close that by sewing it together. But you still can have a urine leak after that. You can have positive surgical margins, a kidney injury, and there's also a risk of infection, bowel injury, injury to other organs such as the liver or the spleen. But overall, long-term outcomes for a partial nephrectomy for tumors that are less than 4 centimeters are quite favorable. There's also something called a radical nephrectomy. This is when we remove the whole kidney. We sometimes also remove the adrenal gland and sometimes remove lymph nodes as well. And so you can see here in the schematic on the right, to remove the whole kidney, we clip the ureter and take part of the ureter. That's the tube that drains the urine that is made in the kidney to the bladder. And then we also cut off the blood supply to the kidney, usually by either stapling or sewing the renal artery and the renal vein. When do we perform a radical or a partial nephrectomy? So the benefits of each we really take into account. So the pros of a partial nephrectomy is that it preserves more kidney function. The cons are that you have actually a higher risk of complications from the kidney repair. So you can have that urine leak that I talked about. You can have bleeding from where we sew the defect back together. And then there is the risk of local recurrence because we're not removing the whole kidney. You can have a recurrence in the remaining kidney. Radical nephrectomy removal of the whole kidney actually has a lower complication risk, but we are removing the whole kidney and we're taking, healthy nephrons or healthy kidney that can contribute long-term to kidney function. So we favor a partial nephrectomy usually when there's a smaller tumor, younger patients, when it's associated with kind of hereditary conditions, or when there's baseline chronic kidney disease. And we favor a radical nephrectomy when there is a renal vein thrombus, because we try to remove, all of that thrombus in the renal vein, or involvement of the collecting system or adjacent fat. Additionally, whether if the tumor has spread outside the kidney, we frequently will remove the whole kidney. If there's more than one tumor, we'll either do multiple partial nephrectomies for each of those tumors. We do that a lot in hereditary conditions, or remove the whole kidney. It depends on how much of the kidney is affected, whether it affects nearby tissue, how well the other kidney works. There is a scan that we can get before surgery to look at the relative contribution of each kidney to overall renal function. So we'll do that a lot if we're considering removing the whole kidney. whether the patient has other diseases that affect kidney function as well as overall kidney function. So there's a lot of considerations that go into removal of just the mass versus the whole kidney, and that's something that we discuss, at our multidisciplinary tumor board as well. I always like to talk about recovery from surgery. And recovery time can depend more on how the surgery is performed than how much kidney is removed. And patients frequently can recover faster from removing the whole kidney than just part of the kidney, just based off of that higher complication risk with a partial nephrectomy. And we have a lot of different surgical approaches. So we can use an open approach, which, as Dr. George mentioned, is the traditional approach. Patients have a larger incision. It says here best visualization. I'm going to argue with that a little bit. I think the robotic approach gives us pretty awesome visualization. But we do use it a lot for complex tumors. We can do laparoscopic approaches, which are minimally invasive, and I'll kind of go into the more detail on an additional slide, but it does have reduced recovery time compared to the open approach, but it does require a lot of technical expertise. And then I would say at this point, at least at UNC, we most frequently use the robotic assisted approach. This has enhanced dexterity, 3D visualization, and a shorter learning curve, and I would argue is kind of the quickest recovery for patients. So for open surgery, we use this the most for large tumors or tumors that extend into the vena cava or complex tumors. As you can see here, we're using kind of surgical instruments directly in the surgical field with a larger incision. We make a cut kind of along the side or on the stomach. And honestly, we at this point kind of rarely do this approach, except in those conditions listed there. Laparoscopic surgery is where we make a few small cuts and we put a kind of ports in, and then we can put instruments in. This differs from the robotic approach because we're putting in instruments, and as you can see here, I don't know if you can see you can't see that. Let's see if this works. As you can see here, the surgeon's hands are actually on the end of the instrument. So the instruments are in the body and the surgeon's hands are on those instruments. Robotic surgery is similar to laparoscopic surgery, except these arms here are actually attached to the instruments, and then the surgeon is over here at this robotic console controlling those instruments. This allows for very minute movements and very precise movements in the body, and really gives us a lot more control than the laparoscopic approach. As you can see here, has less blood loss, shorter hospital stay, and fewer complications. The majority of patients that undergo robotic surgery can either go home later that day or the next day. Of course, if there's complicating factors, we keep patients longer, but the majority do go home in that short time interval. And after surgery, most patients do well. We typically say no heavy lifting for a certain amount of time, and no strenuous activity, but overall patients do really well after kidney surgery. Questions that you should be asking your surgeon if you're going to have surgery. How long will it take? How long will I be in the hospital? When can I drive? When can I go back to work? And what's the most important thing I can do after surgery? And the answers to these are really dependent on individual patient factors, as well as surgeon factors and preferences, and the approach that you have for your surgery. In general, patients stay 0 to 5 days in the hospital, return to activities in 1 to 6 weeks, and usually have a full recovery in about 2 to 8 weeks. And as I said, most patients do well. So in summary, surgery for kidney cancer, we usually, when we can safely do a partial nephrectomy, we usually do recommend that over a radical nephrectomy. A partial nephrectomy does have higher complication rates, and open surgery is usually reserved for very large masses, complex masses, or for masses with tumor thrombuses. And a tumor thrombus, I don't know if I kind of explicitly said this, is when the tumor extends from the kidney into the renal vein or into the vena cava. So it's kind of leaving the kidney going into the main vasculature. And then once recover, I would say minimal long-term impacts on quality of life, minimal to no. And then it's really important to keep your kidneys healthy long term and to really control blood pressure as well as blood sugar.